Dr. Kevin Most, Chief Medical Officer for Central DuPage Hospital, Northwestern Medicine, taking care of the doctors that take care of you and me while he doctors it up himself. And how are you, Doc?
I'm doing great, Steve. How about yourself?
Doing just fine, thank you.
And he looks pretty good, too. His color looks good today.
And I got a haircut.
Mm-hmm.
Oh, good.
Is my color off some days? I mean, I'm pretty consistently bronze all summer, aren't I? Bronze god?
You're a bronze god, yeah.
Correct.
Physically fit, picture of perfect health right over there.
Can't believe I didn't get bronze god out of you before now. Doc, speaking of sun, we think of Jimmy Buffett. Did a extensive tribute to him yesterday. And the skin cancer that would end up taking his life seems pretty rare and pretty aggressive. What do we know?
Yeah, when we've talked about skin cancer, and really any time we try to educate people on skin cancer, obviously we look at the melanoma, the one that is the worst and the most common of the worst, over 150,000 cases, and we talk about the A, B, C, D, and E of melanoma. Now, Merkel cell cancer, there's only a couple, probably under 3,000 cases, if I'm not mistaken, a year. But those are expected to increase just because as baby boomers age, this is a cancer that's often over the age of 50, often found on the neck or face or head. It kind of gets confused with other cancers because it's a painless little bump to begin with. And unfortunately, it sits under the skin. So you see this little bump, and you're not sure what it is, and you just kind of leave it alone. But unfortunately, it's an aggressive skin cancer that when it breaks through the skin and gets kind of a shiny look, kind of pearl-like look, it's often metastasized by that time.
Wow.
And gets into the lymph nodes. That's how it kills?
Yeah, it could pretty much go anywhere, very much like melanoma. It just kind of spreads, and as the cancer cells, unfortunately, when they spread inside the body, we don't see it until we have other problems, whether it is in your lymph nodes, in your liver, in your lungs, wherever it happens to go. By the time we start to see those problems, whether it's pain or jaundice or whatever, the cancer has already spread, and it's very difficult to treat.
Well, let me ask you this. Because it's so unsuspecting and it's something you think, it's just a little bump, can it be detected at a skin appointment if you go for a yearly exam?
Absolutely.
Like in the early stages?
Correct. You hit it right on the head. A lot of people say, I got this little bump, and they just kind of leave it alone. And if they don't get into the dermatologist who's going to look at that and measure it and say, okay, how long has this been here? What's it been doing? Has it changed in size? Because it can be very aggressive. Those are the experts that we need to take a look. And we've emphasized how important it is to get in to see a dermatologist and how difficult it is as well. But yes, because if found early enough, they can do Mohs surgery and essentially cure you from this and prevent it from spreading.
I also want to ask you about Mitch McConnell. That's another news story that's out there. Obviously, he's had two incidents where he kind of stares off into the great beyond and seems unresponsive. Congressional doctors cleared him to go back to work, said it's a case of lightheadedness, and the EEG showed no damage. But as reported this morning, EEGs, and you tell me if you agree with this, EEGs don't show damage. They show what's going on at that point in the brain?
Correct. Now, sometimes an EEG will show abnormal spikes even when there isn't. But for some of these where it's just this thought of as a seizure, the EEG is very much like an EKG, right? We're checking the electrical activity of the heart at a certain point in time. So EKGs for our heart will show where there's been damage sometimes. So you'd say, wow, you had a heart attack years ago. I don't remember that. Well, it shows, and we can actually identify which part of the heart has been damaged. Not as attractive or not as accurate, I should say, in the brain with EEGs. So looking more at the current electrical activity, and what we try to do, we put people on EEGs here for 24 hours, monitoring them, looking for that seizure activity and trying to capture that seizure activity. So again, we can identify essentially where it's occurring in the brain.
The years that you've done this, and you've been a doctor for a long time, you ever encountered what McConnell appeared to be going through where it wasn't an assumed stroke or something like that?
Well, it's interesting. Everyone's talking about this post-concussion, and certainly it appears to be. He's at every test that would be recommended and probably another 100 tests on top of that probably wouldn't be needed, but they're going to be as thorough as they possibly can. I kind of go back to saying, okay, what about when he fell?
I was going to say he fell and had that concussion. Could it be related to that?
Exactly. Related to the concussion or what made him fall. And, now we look at post-concussion. Well, post-concussion in a high school football player is totally different than post-concussion in an 81-year-old. So we certainly really have to keep a very close eye on him. And, is it concerning? Yeah, it's concerning. I think it's concerning any time you have somebody that's in a position of authority, whether they're a pilot or a politician. We need to be careful to make sure they're making the right decisions.
You get over the age of 60, and I know a guy that's over 60.
Yeah.
And the good doctors and nurses and staff at Northwestern Medicine, amongst the questions they ask you is, are you concerned about falling? And of course,
that one.
Yeah, my response always is, I don't know. You're going to trip me? I don't.
You gonna catch me?
But what is it about getting older that leads to the higher risk of falls? Is it the lack of balance related to a lack of physical activity, or is there something that goes on with aging that doesn't allow you to have that same equilibrium? What is it?
Yeah, it is a combination of things. We've talked a little bit about peripheral neuropathy. Our nerves don't work as well, not only telling us where we're standing and how we're standing, but also to fire as quickly in a response to a change in an environment to prevent a fall. We know that our equilibrium in our brain doesn't work as well. We know our vision is not as good. There are so many reasons that we fall as we age. And probably, like you said, we're in the hospital setting, we're always concerned about that, as people should be in the regular setting, because unfortunately, falls in the elderly, we don't count them usually as causes of death, but they often are the cause. In other words, they fall, they broke their hip, they laid in bed, they got pneumonia, they died from pneumonia. So it's one of those where we really need to make sure we have strong bones, work on our vision as much as possible, work on our balance. Individuals that as they age, if they can do Pilates, light exercise, swimming, all those things that keeps them active, it keeps their brain active, but probably more importantly, it keeps their body in as best shape as it can be.
I'm glad you said that, because I was going to ask this, and I was going to say it's a silly question, but can exercise help with balance and stability? So even light exercise every day at any age? Because I've always been a big advocate. Exercise fixes everything.
Absolutely, Jane. And, and people say, well, I don't have the stamina because of heart disease or lung disease. Okay, then do yoga, do Pilates, do things that are going to work on your balance. And actually, people understand that many of those exercises that aren't out going running around the block or lifting weights actually work on your core as well as your balance, which are the two things that are probably the most important as we age.
When we come back, COVID update. Yep, it's back, kids. Just in time for the fall. It's back to school, back to work, COVID. And I know several people who have had infections and or exposures recently. And, of course, the first thing I do is tell them, get away! We continue with Dr. Kevin Most, Northwestern Medicine, Central DuPage Hospital. Hello and hi to everybody there. All the great staff, the admin staff, everybody that is involved with taking care of folks. And obviously the nursing staff, everybody else. You got great folks there, Doc. You know that, but we appreciate the work they do.
Yeah, thanks, Steve. They often aren't thanked for that, and we're so appreciative, and we're very fortunate. It's fortunate to have the staff we have, and we try to keep them as happy as we can so they stay with us.
Let's see, 847, super informative segment with Dr. Most, and now you're going to ruin it with COVID stuff, blah, blah, blah. Well, before we ruin it with COVID stuff, thank you for listening, 847. And the science and information that we bring you can do anything you want with it. A long time ago, Dr. Most and I had talked on the air and off the air, said, look, you can't change those that don't want to be changed and don't want to protect each other. We're going to be living with COVID, as you forecast 3 years ago, every fall. And at other times, and be concerned about others in your life. Older folks, people who are vulnerable, people who are undergoing cancer treatment, and don't spread anything to them, the same way you wouldn't want to spread a cold to them. That's all. It's not political. That's all.
Yeah, it is. And, unfortunate they feel that way, but, they'll probably appreciate what I'm going to say in the next, 30, 45 seconds as well with just what's going on.
So how much of a rise are we seeing?
Well, it's interesting. We are seeing a rise. We're seeing a bump, and we're seeing a slight bump in hospitalizations. And you probably all have seen this BA 2.86, and it was the big concern, right? 36 mutations. And once it was identified, everybody kind of got a tizzy up saying, oh my gosh, what is going on with this one? But there were so few cases. Well, over the last couple of weeks, we've identified enough cases now to find out three main things that are probably really important. One, it's less contagious, which is a rarity. Usually the variants end up being more contagious. Two, mild symptoms, so it would not be surprising if Dr. Biden has this strain. And three, the probably one that the most important is that, because we're all concerned, could it evade the vaccine immunity? And it has proven not to. So the new booster that's coming out is very effective against this BA 2.86. So this is not the sky is falling, let's run away. This is, hey, you know what? The strain is out here. We know it's less contagious, but it's mild. But we also know that the vaccine works. So this is not a hype run-up, let's get concerned. This is a reassurance that science is doing what it's supposed to do. It identified one that had a lot of mutations and was concerned. It did the testing on it, and now it's sharing the information.
So, Dr. Most, that booster that you say, that's not expected out until October, or is it available now?
No, it's not available now. We're expecting it in the second week of September. I haven't seen, when it's actually going to come out. I don't know if it has set a release date. We expect it before the 1st of October. So I would say it's either going to be out end of next week or the following week. And people have to understand that if you haven't, everyone got that booster about a year ago now, and then we didn't approve the second booster until the spring. And many people were kind of hesitant, held off, saying, you know what, I'm feeling pretty good. It doesn't seem that bad. So now that other booster, which was focused on BA4, BA5, is gone. And now the booster that's going to be recommended, starting here in a couple of weeks is XBB, but it covers the BA 2.86. Now, I get so frustrated when people use acronyms. In the last 15 seconds, I use BA4, BA5, BA 2.86, and XBB. I guess the big message is the vaccine that you're going to be hearing about is very protective against the current strain that we were concerned about.
Same sort of rotation on who can get it as usual, most vulnerable and people with preconditions?
Well, we don't think there's going to be a shortage, so we think there's going to be two things. One, there's going to be plenty of vaccine, and two, we also have seen that the apathy in vaccine has dropped, or has risen, I should say. So we have a lot of patients who are going to kind of wait and see or not get the vaccine, but I would certainly prioritize individuals that, like you said, immunocompromised, diabetics, heart disease, those over the age of 65. Certainly you want to protect yourself from this because even though the symptoms appear to be mild, they can go on to other things which you don't want to happen.
And then you always recommend we get a flu shot. Can you get those at the same time, the booster and the flu? Okay.
Yeah, you can, and I would strongly recommend it. Getting them both at the same time is going to be one of those where you're going to know you have it versus, I got to go back for that. Our immune system is wise enough and smart enough to identify two things and make the appropriate antibodies to those foreign vaccines that we're using. So certainly you can get them both at the same time. It's been well proven.
And obviously it's going to be a major news story when it's released and ready to go and all that. But we'll be getting these through our pharmacies?
Yeah, you can get them at your pharmacies. I don't think you're going to see a lot of doctors' offices carry them. I think it's going to be mainly pharmacy-based. You'll probably see some stand-up clinics as well, just to make sure that we can get the people done as quickly as possible. We certainly don't want to go into the fall like we were last year, where you saw this triple-demic of RSV, flu, and COVID. So anything we can do to protect ourselves to slow the spread is what we're going to attempt to do. And that's why it's encouraging that this new strain appears to be less contagious, which I said, again, is very unusual. Usually a new strain is popping up because it's more contagious, so it can spread more easily.
I want to get to an interesting text before we run out of time here, but just quickly, the vaccine issue being covered, the masking thing, which pisses a lot of people off, which frankly I'll never understand, but that doesn't mean you and I have to agree on it. People that freak out every time somebody mentions a mask. We're seeing people wearing masks now. What would trigger wide mask mandates with politicians again?
Yeah, I don't think you're going to see it because what we're seeing now is the strains, as we've evolved, have put less strain on the hospitals, and that's probably was the biggest tipping point. Is remember that not only the strain on the hospitals, but showed that those strains of the virus cause hospitalizations. So that was the tipping point, definitely. And I don't think we'll see that. I think you might see employers put it in place. I think you might see hospitals put it in place. And again, it's to protect the workforce more than anything, as you're going to start to see, like you said earlier. Everybody knows somebody who has COVID right now or has had COVID. So we're trying to protect our workforce to make sure we can take care of those who are in the hospital.
The RSV vaccine, we don't have time to cover it and give it its due here, but we're going to post the notes, as we always do with the podcast of this conversation, at WLSAM.com. But can you get the RSV vaccine at the same time that you're getting the other shots?
You can, but again, now you're talking about RSV for those over the age of 65. But I think the RSV, and we should save it because it's a very interesting way for us to vaccinate people, and actually who are we trying to protect. So the RSV vaccine that's been approved for the pregnant woman is not to protect the woman, but actually to protect the fetus when they're born, the newborn.
It's a big deal.
We should talk about that one later because, it is a big deal.
All right. Lastly, I just thought it was a really interesting question, 219, and it's a big question, so it's a little tough to answer quickly. But it said, my wife was on Synthroid for several years before we got married. Once we got married, my insurance company denied the coverage, went through the whole process of appealing, finally did get it passed. However, the doctor lowered the dosage, then the insurance company denied it again, so now we got to go through the whole process, jump through all the hoops again. Is there any way to avoid all of that nonsense?
It's crazy. So Synthroid is a drug that we use when we don't make enough thyroid hormone. So we're hypothyroid, and people get lethargic and they put on weight. And we know that you need to have this drug, thyroid, to circulate in our body. It kind of tells us about our metabolism. That varies throughout, and the need for it can vary throughout. So we do blood tests called TSH, thyroid stimulating hormone. When we do that blood test, it tells us, are we on enough Synthroid or are we not on enough Synthroid? So to change the dose is based on science, not based on insurance. So it's unfortunate that he's going through this, and kind of weird that the insurance company is saying anything at all, because unless they're saying this is a new condition and not looking at her previous condition. But certainly very unusual for medications, kind of like insulin. We use insulin for diabetics. Sometimes we change those doses based on their hemoglobin A1C, another blood test that tells us how their blood sugar is doing. So certainly the science behind this and the use of medications is based on what we know is going on in the body. So unfortunate that he's going through that. Please keep pursuing it because it's a drug that you absolutely need for your metabolism and for your health.
And you could probably also take a generic version of Synthroid too, if that's available.
Well, yes, there are synthetics. So if that's the issue of saying we don't want to pay for the brand name again, then certainly look into the other options.
And most doctors' offices have an insurance specialist, so before you leave the office, talk to them.
Yep.
Dr. Kevin Most, thank you, sir.
You got it, guys. We'll talk soon.
Thanks, Dr.
Most. CDH Hospital, Northwestern Medicine.